Okay. Sorry, Alice. We were trying to sort out some technical issues, but I think we are getting there now. We'll be starting shortly. Just hold on. Hey, Doc.
Can you see me now?
Yeah, happy to have you finally.
This has been a struggle, isn't it?
Yeah, you may just have to turn your volume up a little bit.
Is it better now?
Yeah, we can hear you, but you're still a little bit faint.
How about now? Is it good?
Yeah, I can get you, but you're still a little bit faint. Are you able to just increase your volume a little bit?
Let's see.
Good evening, BT. How are you? How are you, Molly? Vutiwe, how are you?
Okay, how's it now?
Yeah, we can hear you, though not as loud, but I think...
Okay, how's it now? I'm trying to connect through my tablet. Is it better now?
Yeah, a little bit better, and if there's still an opportunity to increase the volume a little bit more, that would be great. Yeah, a little bit better, and if there's still an opportunity to increase the volume a little bit more, that would be great. Yeah, a little bit better, and if there's still an opportunity to increase the volume a little bit more, that would be great. A little bit better, and if there's still an opportunity to increase the volume a little bit more, that would be great. A little bit better, and
Okay. I think I'm at my max now. I'm trying to figure out where I'm missing this. Yeah, my volume is at the max right now.
Or maybe the device you're using is also connected to. Oh, okay. Anyway, people are saying they can hear you, so that's fine. Maybe we can.
So maybe you're the problem.
Yeah, maybe it's me who's the problem.
Technology is a big issue right now, so I
You
can
know,
understand.
the issue with my phone is that it's connected to too many things, so maybe the volume is going elsewhere.
That's fine, perfectly understandable. How's it going?
Yeah, no, I'm doing great. How are you, Doc?
I'm doing well. Good to have.
Okay. Yeah, it's been a while. So the last few days, I think I've struggled with a cough, but I'm getting through it now.
Good to have you back in health.
Yeah, thank you. Yeah, so I mean, I wanted to host you today just so that we can go over a few things regarding the healthcare infrastructure on the African continent. I do understand that you've been so keen on addressing some of these issues on the continent. I know you've been writing a lot about just generally how we can improve healthcare systems on the continent. So I figured maybe we could have this conversation and just exchange notes to see exactly what's happening in that space, what opportunities are there, and what sort of challenges are there as well. So maybe as a way of kickstarting the conversation, maybe you can just briefly tell my followers who Dr. Hamza Asumah is and what you've been doing over the last few years.
All right, sure. So I'm from Ghana, and I'm a Ghanaian, and still proudly Ghanaian. I completed medical school some 13 years ago, which is a very long time. So when I finished, I was privileged to be in a system where I had the opportunity to explore other options. So what happens is, and just to give an overview, when you finish medical school, and I'm sure this translates into a lot of African countries, you need to do a 2-year mandatory training as a houseman, which is under supervision. And then after that, you get posted to a different health facility that you need to work. So I took a bold step. I resigned from the government sector after the 2 years and went purely into private practice because I felt there was something more I could do. But in order to be able to accomplish those, I have to get into a position where I can amplify that impact. And I felt healthcare leadership was one of those places that you can do that. So I went into private practice, and from then it's just been trying to build healthcare within the private healthcare space, attempting a lot of my work has been in healthcare accessibility. So I've been very passionate about creating access to healthcare because it's not enough to just have all the infrastructure and all the building available. There's a piece where we have to connect these different structures together. And a lot of my passion has been how I can connect this and then within the entrepreneurial space. So whilst I'm doing that, how can I build more capacity? How can I build businesses? How can I give people more opportunities to grow? So that is how a lot of the work I did in Ghana. And then I came to the US in 2019 where I met you. And then I came back again in 2021 to do my MBA because I realized that we can grow healthcare through entrepreneurship. Regardless of what we think, there's a very huge space there. So I came back, I did my MBA, and I've worked in healthcare leadership after that. And I'm really happy with where things are going because of the potential impact it could have.
Excellent. So from your perspective, how do you currently see the state of affairs infrastructure-wise on the continent? Are we making progress or are we stagnant?
So, Jacob, to be able to address this holistically, we need to put it into context. And that context will only come when we look at where we came from and then where we are now and possibly where we are going. If you look back, we have a situation where healthcare has been, we had a period called the Paleolithic period, where healthcare has been more about small communities. We're mostly hunters and gatherers. We mostly just had a lot of um, people who would just move from one place to another. So we didn't live in very big communities. So we didn't have all these problems of epidemics. We didn't have all these problems of diseases that are transmitted all over. We moved from there to a place where, mostly in the Neolithic period, where we had agriculture. We started keeping farm animals at home. We started staying in one place, places for longer periods. We started staying in bigger communities. At that period, we started transmitting diseases from animals to humans and from other humans to other humans. That's the beginning of how our structure was. And that was how we started treating disease with traditional healing. We started treating diseases with a lot of herbal medication. Now, that was how our healthcare was set up until we had all the pre-colonial and the colonial periods. Because when they came in, they realized that our healthcare structure wasn't enough for them. So whatever was built was so that if they were in the country and something happened, they had access to Western medicine. But a lot of these were passed down to us after at the post-colonial period when they had to leave. Now, during that period, we also need to understand that a lot of diseases cross borders because we started having trading. People started coming in and we started having a lot of trading. So if we look at how we are evolving, it gets to a point where right now we need to look at when we took over the health infrastructure, what have we done? And that comes to answer your question. Because we took over when they left and we started investing into all these things. What has happened after that? What have we been able to accomplish? Now, there are a lot of things that are happening. First of all, there's a disease burden in Africa, which unfortunately is not experienced in other continents. So we are spending a lot of money fighting diseases that we could otherwise prevent. So this is already putting a strain on the resources we have. But when we extend that beyond just the disease burden, we are having healthcare structures that are poorly underfunded. We do not have. So let me take us back to 2011. There was an Abuja pledge by African countries, and that pledge was that we would allocate at least 15% of our national expenditure into health. That was the agreement. So a lot of African countries pledged that. But can you, out of 51 African countries, can you tell me how many people actually did it? We
No.
only had 4 countries out of 51 who actually followed that pledge. And fortunately, Zambia was one of them. You understand? So a majority of people started allocating between 10 to 15% of their national expenditure on healthcare. And we had another significant percentage, about 25 countries actually, allocating less than 10%. And we still have some countries who allocated less than 5% of their healthcare expenditure. So apart from the disease burden, which is already putting a strain on our healthcare systems, we've extended to a point where we have our healthcare infrastructure being underfunded by the governments. So it becomes a problem. So that aside, so that's the problem that has to be fixed from the top. And that will come with a commitment on the part of a government or anybody to say, look, this is a pledge we made and this is something we need to stick to. And that's the only way we can build the structures. So healthcare accessibility is still a problem because we are not getting the funding we need to be able to build and expand that. So if we go beyond and build this out, that is when private healthcare practices started coming in. Because we only had government hospitals, we only had mission hospitals at that time. Now, when private healthcare started coming in, they didn't have the funding to be as big as the government ones. So they only did very, very, very basic primary care. Now, as time evolved, private investors started putting more money into private healthcare because it was a business now. No longer, they made more money from it than they should be making, if I should put it that way. So now it became a service that didn't solve the problem of access. It actually created more convenience and more luxury for the people in the middle and high income societies. So the people in the low income are still struggling. But again, just to be optimistic, my belief is that if we're able to pull those in the middle and high income into the growing private healthcare sector, then it creates a lot of space, it creates availability in the government and the mission hospitals for those in the low income sector, right? But
Correct.
that is me being optimistic, but that is not the reality of the situation. We are still having cases where, as I said, our healthcare infrastructure are not communicating somehow. So I know I've worked on some projects with you, and some of it was to make people aware of what is immediately in their locality, because people don't even know. So someone can drive past the nearest hospital and they don't even have an idea that there's a hospital that exists there. And probably by the time they get to the far off one, something might have happened. So this is this is where we are now. And I know maybe as the conversation expands, we will see what improvements have come in. But technology has become a very important part of our healthcare, especially after COVID. It's become so important, and I think it's a sector that is growing really quickly. So, I mean, as we extend, maybe I'll be able to add more to what Israel has been in the healthcare sector.
Yeah, no, that's a very elaborate explanation. So as I was looking at this topic, one of the things that I saw was that I think on average we have like 100,000 people on the continent only managing to access one intensive care bed. That's the
Yeah.
statistics that I got. But that in itself is not only alarming, but it raises questions in terms of why we are not scaling despite all this funding that we are getting from the European community and from all sorts of donors. What has really been the challenge in terms of scaling our healthcare facilities?
So it's a good thing you brought up the issue of donors and all these people we get. See, for a very long time, there's been a misalignment between the actual need and the reality of what we need on the ground and the priorities of these donors. And I'll explain. So a couple of years ago, I don't remember exactly when, Rwanda actually got funding of about $46 million for HIV. Meanwhile, at that time, the prevalence of HIV in Rwanda was just 3%. Now, at the same time, the funding that was available for malaria, which was the highest contributor of deaths in Rwanda, was 18.3 million. So we have lost touch of the reality where foreign partners, foreign investors that come in with the aim of helping our healthcare infrastructure are either misinformed from the ground of what the reality of our situation is, or they come in with their own priorities and their own program outlines, and we have to make it fit because we need the money, right? So if I have 46 million to fix HIV-related deaths, which were at that time prevalence was about 3%, and I had all these deaths from malaria, which would have been more significant on our The second thing I would say is that whatever we decide to say, wherever we pretend to say, corruption still plays a very, very, very important role in how we allocate this funding. Now, despite the fact that some of these priorities are misaligned, there is still a chance that even if this funding comes in for the right purpose, we will still have people in power who have the authority to use these funds for the intended purposes, looking at ways in which it can benefit them as individuals. And corruption is not just at the higher level, it trickles down at every level, even to the lowest person in the country. So we need to actually be very, very realistic of our situation and actually say that if we are having these issues and we have all these monies coming in, one, are they aligning with all the problems we have? If the answer is no, we need to have a conversation with these interlocutors. The second thing is if they're actually aligning and they come in and we are still not seeing impacts, we need to have a conversation with people in government and make sure that the money is used for the purposes for which it's been brought.
Yeah, maybe, sorry, not to
Yeah.
cut you short. So, as you were trying to explain that, one other thought that crossed my mind was: are we really giving healthcare infrastructure the seriousness and concern that it deserves? Because looking at the figures that I was reviewing earlier on, I think there's an estimate that in order for us to bridge the infrastructure gap, we need to be spending at least somewhere in the region of like $20 billion every year. But our governments are only allocating about $4.5 million towards healthcare infrastructure. So are we taking this situation seriously?
No, the data doesn't lie. And when you have data that points to the other direction of what we are doing, it just means that we are not giving the priority it needs. And the question I would ask is why? Because this is a serious question of life and death. And when we strengthen the healthcare system right now, it's generational. We are not just doing it for the people we have right now. We are doing it for generations. So my concern is, and my simple answer to your question is, in my opinion, no. We are not giving it the attention it needs. If we want healthcare to really scale to where it's supposed to be, we need to, first of all, as I said, fund it as it's supposed to be. And then from that funding, we modify behavior. And that behavior comes in how much effort people put in preventing diseases. What is the behavior people put up when they have diseases? Do they wait and do all the traditional herbal medication and only wait till it's worse before they go to the hospital? So we fund and then we modify behavior. If we modify behavior and we don't have the funding, our healthcare systems are going to collapse because it will be so much that we will not be able to handle it based on the resources we have. So there should be a balance of the two. And right now, we really don't have a balance of both of them are out of scale.
I agree with you. So I think coming to your point, we recently saw how the COVID pandemic just in itself tested our healthcare systems in terms of how resilient they are and in terms of how they are able to respond to some of these events. And what came out clearly was the fact that all along we haven't been ready. Now, given the direction that the globe is going, especially in terms of these climate change events that we're beginning to see, how are we supposed to build that resilience in order for us to respond to some of these events?
So I always, and I'm a big fan of always going back to the fundamentals. What infrastructure, what foundation did we put or did we propose as the foundation for healthcare infrastructure? If we don't go back to that conversation, then if we build on top of anything we have right now, it would not work. So yes, COVID really exposed it exposed a lot of healthcare systems worldwide. People thought they had very strong healthcare systems, and it broke through every single one of them. What a lot of governments are doing now is going back to see what they did wrong. Which part of that infrastructure did they get wrong? And once you get it, you need to fix it at the foundational level before you build on it. What we are doing as African leaders is wait for another pandemic to strike. That's what we are doing. Because post COVID, I would have wished that we see bigger conversations in how we can really develop healthcare. Like country by country, we should have seen extensive policies, directives on how we can rebuild our healthcare infrastructure. I dare say that there's no single country right now that is actually paying that much attention to it because, again, we still are allocating way lower amounts of money from our national expenditure budgets to healthcare. So the people, the players, the people in charge of building this infrastructure do not have the resources they need to build them. until we get to a point where, as again to your point, we start taking this as serious as it's supposed to be, we will not get there. But I would say I haven't seen a single country in Africa that is giving it the attention. We are not learning from the lesson. So we are just waiting for another pandemic to come in and we see how it happens. Maybe, just maybe, another reason may be that other countries we didn't experience the depths that some of these European countries experienced. If we put on the TV every day and we saw people dropping like they did in Europe, in America, in other places where there was just a huge compromise of people's immunity with age, I think we would have taken it more serious. Africa was lucky not to have that level of that toll of death. But again, as I said, we need to go back to the foundations, which we haven't, and which we are not. I doubt if we will do that.
Yeah, I seem to agree with you on that point. And for me, what really bothers me is the fact that most of the conversations around healthcare have been on improving accessibility. But why are we talking about accessibility when we don't even have the infrastructure? What are we supposed to be accessing?
Exactly.
So I don't know what your views are on that, but my take would be that our focus right now should be on improving the infrastructure. Once infrastructure is in place, we build the systems. Once systems are in place, then we start talking about access. Is that the
Exactly.
right thought process?
I agree with you totally, and I'll tell you this from my personal experience. So somewhere in 2014, as we started building a healthcare database, right? We started trying to put healthcare and hospitals, give them some online presence. Make sure if people need to see them, they would be able to find them. That was one of the most difficult projects we ever did. Simply because, in our opinion, we thought using technology to bridge these gaps was going to be the solution. That wasn't, because it came before its time. Timing was a big factor. So healthcare wasn't at that time. If you had any conversation with anyone about healthcare, the focus was mostly on physical structures and not using technology to access those physical structures. So that was never a conversation at any point, never. So I will say yes, I agree with you. It shouldn't the until we get to a point where we have the infrastructure in place. All these conversations we're even having now on technology and all these other things in healthcare, it's going to be a very difficult conversation to have because we will not be able to use it effectively if we do not have the infrastructure to support it. So again, it's going to be an issue of timing. We are going to be putting in strategies that are not ready yet. And so we're going to have people frustrated. We are going to have entrepreneurs putting lots of money into building sophisticated tools only to fail. We are going to have governments investing in sophisticated technological stuff only to fail. We are going to have international donors giving a lot of money and getting tired eventually only to fail because priority is still a problem. We are not prioritizing where we have to invest. We are not prioritizing what to invest in first. We don't have a plan. We don't know, okay, these are our problems. Which one is the basic foundation of what we need to build before we build all the others on? We don't have that. Everybody comes in and they take whatever they need to. And I also tell you this, a lot of the delay that we've had has been around governments coming in and trying to accomplish their own projects within the time frame of their governments. There's no continuity of projects. We've had healthcare facilities that have been in the almost completed phases, and new governments come in and ignore all those projects and go on to do completely different things. or start projects from scratch. When if we have projects we could have easily completed, if we need to have a conversation. And I always tell people that if I don't have ambitions of going to politics, but I always tell people that if I ever was in that position, my aim would be to come in and just single project. I don't care what it is, be it healthcare, be it education, be it roads, just go in and complete. We would have had those infrastructure in place by now if we had some continuity in our government speaking roads. And that's where we are right now, unfortunately.
Yeah, that's interesting. And I think having done a few projects in Zambia, that's one of the things that I also noticed. So it's like we don't have this plan where we're able to continue these projects, even though this particular government is out of office, which I think for me is a little bit unfortunate. But then I wanted us to touch a little bit on the issue around accessibility to healthcare infrastructure. So from a layman's perspective, how would you describe access? What really is access to healthcare?
So when you talk about access to healthcare, so many things come into play. So people think when we say access, it just means is there a physical structure there that I can go in and get healthcare? No. Access should probably have about what, like 5 components. So first of all, one of the biggest determinants of access is affordability. If you have the physical structures available and you don't have the money to access them, then you have an access problem, right? And depending on the population you have. So I'll use the United States as an example. Healthcare is expensive in the United States. So I can easily walk out of my apartment and I'll find a hospital or something just close by. But without health insurance, I will not be able to pay because it's so expensive. So in that case, it's not about the physical structure, it's about the money, right? We have an issue with just availability. That's why the physical structures come in. Are they even there? Are they? Do we have resources? That's another factor that comes into access. So you are looking at money. That's one. You are looking at the physical structures. Are they even there? If they are there, are they there in the right numbers to make sure that you don't have to travel for hours before you get to the nearest healthcare system? Do we have the resources? So we look at how much load is on it. How many people are we serving? Do we have the people to support? As we speak right now, I think the recommendation from WHO is that for every 2.5 doctors, you should serve like 1,000 people in the population. Right? In Africa now, we have about 1.3, serving about 3,000.
Wow.
So that's an access problem. So it's not. This is no longer a question of physical structures. It's a question of human resource, right? We have another component of access that has to do with just what time is the facility open? What are the appointment times available? Do I have to wait for long periods before I get an appointment to see a specialist? Stuff like that. They hinder access. And the last one is just cultural. Do we have providers that are culturally sensitive enough to offer the kind of healthcare that they need to the population? If I have a US trained doctor who goes to Ghana, does this person have the culture? Maybe let's assume the person was never born in Ghana, the person was born in the United States, schooled in the United States, has no idea the cultural nuances we have in Ghana. Does this person have the expertise? So in that case, you're not talking about human resource because you have a doctor. You're not talking about the accessibility because you have a program. You're not talking about availability because the person is around, right? We are now talking about acceptability. How would they accept this person? If I sit in front of this person and I have a conversation with them and I feel they don't understand me, will I go back to them? No. So that is a component of access. So most of the time when we talk about access, people think, let's build more hospitals. But if you build more hospitals and you don't add people, you don't train more healthcare professionals, you're not solving the problem. If you have more healthcare professionals, have more hospital buildings, and they cannot afford it, you're not solving the problem. If you have them and you bring, so we used to have a huge surge of Cuban doctors coming to the country. And it was very difficult for people. So you have communities where they have Cuban doctors, but these people also travel hours to meet with local doctors because they understand their problems, right? They understand their diseases, they understand their problems, they understand the socioeconomic settings and everything. So if you want to talk about access, all these things are these arguments and before we get
Absolutely. So, in your own words, what do you think should be the approach that we should take in terms of just improving healthcare access and linking that to infrastructure utilization?
are you talking about just COVID or just disease?
Just in general.
If we're going to talk about the issue of access, first of all, it depends on our approach. Are we looking at providing access on the population-based level, or we are providing access on that level? Because those ones, the priorities will be different depending on what our approach is. For instance, if you ask me what we should do now and how we should go with that, my first one would be have a national health insurance, a very practical, sustainable national health insurance that can offer universal health care, meaning that everybody in the country would have access to basic health insurance and access to health care. You walk into the hospital and they will see for free, but it is sustainable. The problem we have with our national health insurance systems and
Sorry, a little bit faint. I can't hear you.
is it better now?
Yeah, I can get you now.
Okay. So I was saying that if national health insurance schemes are not sustainable, then the issue of universal health care is not sustainable. And that's why a lot of our national health insurance schemes are. So my first component would be affordability. I would want to create a system where healthcare is affordable, whether we do it through our national health insurance systems or we have other ways of making it affordable to even the lowest income people. That would be my first thing. And if it's to COVID, if it's to any disease, treatment should be affordable and should be accessible. The second thing would be then I would go ahead and say, let me create the fiscal structures so that when these people who have the the insurance plans to be able to secure healthcare, if they work out, they have fiscal structures they can work with. So that would be my second component. That I'll make sure these fiscal structures are good. My third stage would be to train qualified health professionals who will man these fiscal structures. Because if you do it the other way around, where you have trained professionals who don't have places to work, they will leave the country. They will go to other countries, they will try to get other jobs, and you'll be losing your human resource. Create the structures first and train the people, and they are going to fit right into it. Once you have that people able to come in without any hindrances, they have the facilities to come in without hindrances. And when they walk in, they have the qualified health professionals to take care of them. You have solved over 80% of your accessibility problem. Everything else you need to do from there are just little nuances that you need to adjust here and there. Do we have enough resources in terms of what they need to work with? Are we giving them enough? Those are little things you will adjust if you have these things right. But my first three would be first, create an affordable system. There should be a universal access to healthcare, but it has to be sustainable because it's difficult to build a very sustainable universal healthcare. And once the people have the power they need to be able to access them, build more facilities so that they can walk into those facilities. And as you build the facilities, train the human resource to complement them. And that should solve over 80% of the problems we have right now.
Absolutely. So one of the things that you also touched on was the ability for patients to be able to just pretty much tell what sort of healthcare infrastructure is within their perimeter. And this is one of the things that I've also seen to have worked very well, especially in developed countries, How do you see the opportunity in that space, especially on the African continent? Are we drawing closer to a situation where people are able to utilize technology to access some of these facilities?
Oh, yes. So Africa, so far we have the youngest population in the world, right? And when we talk about technology adoption, any population that has a young population has a high tendency of adopting technology a lot. Let me give you some. I like working with numbers, and I'm sorry if I'm throwing away so many statistics, but numbers inform. They don't lie. They actually give us a guidance on what we need to do. The technology adoption, as we speak right now on the continent, is about 40%, right? We have over five, maybe 570, 580 million people on the African continent who have access to smartphones. That's huge. If we look at how many people are currently um, using all these social media platforms, some of them are even complicated than using health apps. It's a lot of people, right? Now, this is just the numbers in 2022, but these are going to grow eventually. If we look at how much is going to grow, they've projected that by 2028, we are going to have from about 400 million to 500 million people. We're going to have almost 700 million Africans using smartphones. When we put all this into context, what that means is that we have to create a purpose for those smartphones. And if one of the purposes is through the use of healthcare technology, then it becomes a big issue. We might not have the best internet reception in many areas. It will be a challenge. We might not have the most affordable internet packages available for most people. That might be a hindrance. But we do have people who have all these things to do TikTok videos, to be on Facebook and to be on Twitter, to be on all these social media platforms, endless hours in a day. We have people who have the capacity to use them. We need to start leveraging those and channeling some of that energy, some of those resources into how they can use those equipment to improve their health. So I would say that yes, we are well positioned now and in the future because we are still growing and it's just going to get better. And the lessons of COVID has taught us that we need to be in a position where we can even access healthcare without going to a physical facility. COVID has taught us that, and a lot of people during COVID learned how to use technology to do so many other things. Why don't we make healthcare part of that conversation? So that's my opinion.
That's a very good and well thought out opinion, and thank you so much for that. So I know you've done a lot of work in this space. I understand that you've been building a lot of tech-related solutions to address some of these things, not just in Ghana but also in other areas of Africa. And by the way, congratulations on your appointment. I read that you were appointed to a certain board in Kenya.
Yeah,
That's huge.
yeah.
So from the affordability perspective, I know we're talking about driving healthcare access through the usage of technology. How affordable is that, especially seeing that a lot of people on the continent are not only poor, but they don't even have access to some of these facilities that we're talking about?
Let me start. Let me start the conversation from what I built personally. My very first product. So my very first product was it was a combination of a healthcare database. First of all, what I did was bring a lot of physical facilities together on one platform. The second stage of what I did was, after bringing them on one platform, make sure that I bring people on that platform. And now, after that, connect those people to those facilities within the platform, right? What that did was huge, but it cost nothing. We charge absolutely nothing for the clients or patients using the platform. But then when you talk to a doctor or you consult a doctor, you have to pay the doctor, obviously. when you have to go to the hospital, maybe it's something they cannot solve for you online, so you have to go in physically, and you do any services you didn't like, we have to pay for those, right? Those were outside our control. What we had control over was the platform, and the platform was to. So I'm starting from a point where we can actually build these for free, because there are other ways to make money off that platform, apart from charging people to be members. So, but if we extend that conversation, healthcare, especially with use of technology, can get very expensive because it comes with two things. It comes with convenience added to accessibility. So I can sit in my office instead of driving through traffic for an hour or two to the hospital to see the doctor. I can sit in my office and tell the doctor, hey, I checked my sugar this morning, which they would do. I'm diabetic. This was my sugar this morning, right? I checked my blood pressure too. This was my blood pressure. The doctor documents everything. If they have any more questions, they ask you, and they send you a prescription for your refill. So something that would take you probably an hour to drive there, an hour to drive back to the office, and maybe let's say 30 minutes of consultation, that's 2.5 hours of your time, will probably take you about 20 minutes. So it can get expensive because then if I'm offering you that convenience in addition to the accessibility, which we spoke about, then I'm going to tell you, I'm going to give you a package that you're not getting anywhere. So you have to pay probably a bit more for the consultation, but comparatively with the time you lose from work and what the application will be financially for you and your family, it's a nice trade-off. If we talk about those in the low socioeconomic bracket, which is always my passion, those are the people who we need to be very keen on when we bring issues like this up. Education is a problem. Not everybody is educated. So a lot of the projects I'm doing now, and I'm moving away from what I was to what I'm trying to do now, is that any technological intervention that I bring on, I try to translate it. Let's say in Ghana, we have 46 different languages. I obviously cannot translate it into 46 different languages, but I have two options. I can look at the language that is most widely spoken and translate it into that language. Or there are a lot of people who have tools specifically for language translation that I can reach out to, partner with them, integrate them into my platform. They can offer that wide spectrum of language interpretation. Whichever it is, my aim is to make sure that when the person who can read a local dialect takes the app, they have the opportunity to choose, or their child who can read English has the opportunity to set up that in the local dialect for the person. Now, when we start talking about technology, we should never talk about it without the role of AI. No matter what we do, and regardless of how scary AI can get, and how hesitant a lot of people are with AI, we need to understand the fact that it's become a very important part of the future of everything we do, and that includes healthcare. I have started some projects in AI, and I will tell you that it's phenomenal when you consider all these things in AI. Is it more expensive? Yes. Will the person in the low socioeconomic bracket be my target audience? Maybe not. My aim at this point is to test it at a different level and in a different income bracket and make sure that it works before you can think about ways to make it affordable. So in that case, it's not going to be accessible to everybody because of price, but then it becomes affordable. So that's where we want to lead to. But coming back to your question, technology infused with healthcare can become affordable. We just need to be very strategic in how we are going to sustain it, because there is a business. You need to make money to keep the business going, but then you have to be innovative enough to find ways of monetizing that tool without it becoming an extra cost to the consumer. Whenever I build tools like that, I make sure that the consumer is not the one going to bear the cost of my tool. there are other people who can. We have big pharmaceutical companies. Why can't those people advertise for a fee?
Mhm.
We have we have hospitals who are going to benefit from patients coming in and coming to see them. Why don't they be the ones to take up that cost? So many other options that you can make money out of that platform without directly charging subscriptions or any other form of billing for the patient. But then it comes with being very innovative because you need to keep your business running. I'm a business person. I like to make money. I like money a lot, and I know you do like money. So whatever I decide to do, I would want to make money, obviously. But
Yeah.
beyond that monetary gain, I would want to walk into a community where I see that person who otherwise wouldn't have had that much access to healthcare, getting that access without it costing him more than it would have if he walked into a physical facility, but with the additional benefit of convenience of sitting in his home and just talking to a doctor and not having to leave the home. That is where I'm leaning towards. It's a long way to go, but I can tell you that with what I've worked on in different countries, the potential is there.
Excellent. That's so nice to hear. And I think for me, I've also noticed there's been a lot of progress made, especially on the tech side, to see how folks can bridge the gap between access, affordability, and all these nice things. But what I don't seem to get is the policy aspect of it. One, to encourage these tech players to do more. And my other thought is that I don't think there's really a very high adoption in terms of governments taking up some of these initiatives that are going around in the private market. So how do you see it? Is there currently some sort of a conflict between the private and the public sector in terms of adoption of these technologies?
So I would say that one of the biggest tools we have to grow in our healthcare infrastructure is the political framework. But one of the biggest hindrances we've had also to building our healthcare infrastructure is the political framework. Now, the political framework is built across countries, is built to be very resistant to change. Because before you propose a policy change, it has to go through a lot of stages before a policy goes through. You cannot just get up and say, this is a good idea. And trust me, every single idea you have in healthcare is a good idea because it's aimed at saving lives. So that should be the fundamental anyway. But to propose a policy and give it value, because what politicians look for is different from what, let's say, as a scientist, what I look for. I am going to go into that space, Jacob, and I'm going to pay attention to two things. Mine is what is the scientific basis of what I'm doing, right? So I'm going to go with research. I'm going to go with numbers, figures. And then I'm going to look at the benefits on the other end of it. The politician is all about how the sensationalism, how do people feel about this project? How would it make people feel? Would it get me back into power? You understand? So it's a conflict of science and ideology. Now, when you have those extremes, somebody has to compromise at some point. The reason why technology and all the proponents of technology are failing to get the government involved is because they're not willing to compromise. Trust me, that politician will never compromise. One of the things that would happen is a lot of these technology stuff are revolutionary. They cause massive changes. But the politician is scared to take that huge step, invest that huge capital into something that has not been tested. He's not sure how the people receive it. He's not sure how it's going to translate. And his image is at risk. They're going to say, Jacob Mwanza introduced this in our community and it didn't work. So they were voting him out. But as a scientist, I have all my science and all my evidence to back it up. But Again, I want that huge, big jump. The politician wants small incremental jumps. Where does the compromise come in? Ideology, science. If we want politicians to be on board, if we want to win in the policy battle where we have our ideas being translated from science into policies, we need a politician. And that's where the compromise should be. That doctor or that technology person who is bringing that innovation has to start thinking like the politician. And that translates into what's the economic benefit? What is the benefit to the people? How do we make the people feel? What would be the perception that people have about the political government or the political person championing the whole thing? You have to move from that scientific barrier into his space and think like him. And that's the only way. If you get him on board and speak his language, he would be able to translate your science into all these ideologies. Secondly, don't come with big jumps. I've tried it so many times. I've gone with ideas that I felt would change the healthcare landscape in Ghana. But I speak to politicians and they're like, oh, this is a brilliant idea. And the next time you call them, they don't even answer your call. Simply because it's just too big a risk. It's a huge jump from where we are. So what you need to do is start from somewhere. Okay, this is where we are, right? If I add this little thing, it would help people. It will improve healthcare. So let's do that one first, right? And then add another piece, and then add another piece. The politician responds very well to small incremental jumps. So before anything can be a policy or for them to accept and take it and vote on it and push it the way they should push it, the risk should be very minimal. If you go to them with, we are at 1, and you want to propose something that would jump us to 100, you will never get a politician that will sign off on it. But unfortunately, as entrepreneurs, as business people, that's where we are right now. We want to make big changes. We want to cause revolutions. We want to make Facebook kind of changes, right? But then if you don't have the resources to support it yourself, you need a government. And there's absolutely no way you can get the government on board if it's go to those two extremes. No way.
Yeah, that's very true, and that brings me to another question that I had. So, in your case, I know you've done a lot of work, not just in Africa but Europe. You're also doing quite a lot of things in the US. What do you think are some of the best practices that we should be adopting on the continent in terms of adopting these technologies that private players are coming up with?
So the funny thing is the healthcare infrastructure. Let's use the US. It's mostly privately funded, right? In the US, let's say health insurance. It's a combination of private and government insurance. We have the Medicaid and the Medicare and all those ones, but we have a huge market for private insurance, and those people pay very well. They are business people, so they have strategies they use to make money and to pay more money for services, and so healthcare providers and everybody wants to be on those private insurance plans, not on the government plans. So that's the first problem we have in Africa. A lot of what we have, our citizens are dependent on the government healthcare system, which puts a strain on it. So it's not even making resources available for us to even explore these options in technology. So in the US, it's easy for me to jump in and then propose a technology idea without a sweat. Because as soon as I propose it, and somebody can call the insurance company and say, I like this telemedicine thing. I want to see my doctor through telemedicine and I want you to pay for it. Trust me, a huge percentage of the time, the insurance company will say, yep, let's look into it, and they will adopt it eventually. So adoption of technology is easier here because we have the resources, there's money, right? If we go back to Africa, which person, which citizen, which patient has the flexibility of calling their insurance company and saying, oh, Dr. Hamza has a telehealth platform and he charges this amount, and I can use my insurance. So I want you to clear my insurance to be able to use it. Nobody can do that. So my experience working here with best practices has been that money is still the foundation. Funding is still the foundation. When there's a good flow of money, the good flow of funding in some of these things, you get some of these technological adoptions going faster than they're supposed to, right? The second thing is that regardless of what we think, anything that releases dopamine so dopamine is the thing that is like something you release when you're happy. I'm just going to keep it simple, right? Anything that releases dopamine has our attention more. Healthcare technology they are not the sexiest things you find in the planet. So they don't release any dopamine. They don't make you excited. When I'm on Facebook and I see people liking my comments, commenting on it, I'm on Facebook. I can stay on Facebook the whole day. If I go on YouTube and I watch this funny video, then I go and watch this video of this. It's exciting, isn't it? I go to Instagram. Those things are easy for adoption because people have studied the human behavior and they've learned what makes people happy. Unfortunately, the healthcare technology, we haven't gotten to that point yet. But then there's a way. One of the things that I'm working on right now is an AI tool that is supposed to help doctors make more accurate diagnosis from laboratory tests and from images. So from X-rays, from CT scans, from MRIs. But then you use AI.
Okay.
And what we are trying to do is that I'm trying to build that tool. I'm so very much in the conceptualization phase. I haven't really been able to get because I need huge amounts of data to be able to give accurate representation. When you go onto those platforms, right, the doctor would now get that dopamine rush. Because imagine that as a doctor, I'm in a rural area somewhere. I don't have access to a radiologist. I'm just a new doctor. I just passed out of school. I don't have the knowledge to accurately read an MRI scan, for instance. And now I have this tool on my phone that when I have an MRI scan, I just take a picture of it, and this AI system scans it and tells me, oh, I see this lesion here, I see this lesion here, and gives me possible things that could be wrong. How do you think you feel if you're a doctor? You get excited, isn't it? And every day you go into it, you want to see what else it can do. You want to see what else it can do. Then you keep going. That is where we need to get to with technology. And that's what I have learned from here. That if we want to win in that battle of infusing technology into healthcare, first of all, the players of that sector, which are the healthcare providers, have to be excited to use it. It shouldn't be like a chore. It shouldn't be a responsibility. It should be something they are excited to use because it makes their work easy. And it's fascinating, right? As compared to a less sexy technology thing like what I did in my first project. I just put healthcare systems together on one platform. It's helpful, it's convenient, but nobody cares, right? But then now, the lessons I've learned from here and from other European countries is that it's time that when you create that system, find a way to give people that dopamine rush. Because if you do, in addition to its benefit of saving lives and doing everything, it is still going to translate into a tool that people would be excited to use, like the way you're excited to use your Facebook, the way you're excited to use your WhatsApp, the way you're excited to use your Instagram. Learn about human behavior to a point where you can excite the people who will be using it, whoever your population is. And if you are going for the general population, find a way to keep people excited. And that's the only way we can win. There are people who have created healthcare apps now that come with coupons, that come with like some form of reward. So it tells you it's an exercise app. It tells you that you need to get 15,000 steps in a day, right? And look at the two extremes. Let's look at one that doesn't give you any incentives. You are going to get up and you walk whether you like it or not. You walk if you want to, you don't walk if you don't want to, right?
That's true.
There's another one that says that before you sign up to the app, it told you that, can you look at all these things. What's your favorite thing? Oh, maybe coffee, um, sneakers. Like they give you all these things, like perfume. Yeah, you choose what you like most. Maybe you like coffee, right? And then when you go through the app and you listen, your coupons or your incentives are going to come with Starbucks coupons where you achieve maybe 15,000 steps over a week. They'll send you maybe a $10 Starbucks coupon. Which one do you think you're more excited with?
The answer is very obvious.
So you realize that you'll be snowing, right? And that day you will not be
Exactly.
able to walk, but you wear your jacket and go walking there because you're excited to do it. You're excited to do it because there's something at the end of it. So what I'm saying is that whatever we do in technology, it has gotten to that point where we need to be very, very cognizant of the human behavior and how people think. And the reason why we'll be left behind in technology adoption in healthcare is because they are not sexy enough. We need to
Exactly.
we need to
And
be
I
more innovative.
absolutely. And I think Tiflo has summarized it so well. She says, in order for us to win in this space, we need to know the human psychology side of the business, which pretty much relates to what you're trying to explain.
Exactly. I
Yeah.
agree perfectly. I agree with that. Yes.
Yeah. And one other thing that I've also seen, especially in developed markets, is this well-designed, well-functioning ecosystem of all the players in the health sector or industry working together in order to advance some of these interests we've been talking about. Do you see that to be a very huge gap on the continent where all these health players are not able to work together?
Yes. I agree. So and I will always say this at the back of the financial benefits that come with some of these things, right? If you have a plan that financially benefits all these players who are involved in the healthcare space, that's first of all, everybody wants to be a part of it and everybody wants a piece of it, right? We haven't on the continent been able to come up with a very sustainable, innovative way to make whatever we decide to work together on to be appealing to all the players that are involved. That's the unfortunate thing. Even if it's appealing enough, we don't have enough data and we don't have enough success in the field to justify it to the players to put in as much attention as it needs to be. So where we need to start from is we need data first. We need to have done these things on so many different levels and at different scales. And we need to go back to these same players and say that when I did this or when we did this, this was the benefit or this was the outcome we saw. Right? As soon as we are able to get to that point, it's going to be easy for them to buy into the idea very easily. But without that collaboration, it's going to be hard because it's easy. You're going to work with these players anyway, regardless of what the situation is, whatever the thing. And I don't think the United States or any other developed European country got to this point all at once. The adoption was slow, it was painful. It came with people coming in, not succeeding, going back out, seeking private funding, which we don't have on the continent, building out the idea, proving that it's a sustainable idea, proving that it's a helpful idea, proving that it's a very beneficial idea. And then I'm coming back to a place and said, I told you so. On the African continent, I would dare you today that take an idea and walk around and nobody will fund you for it. Nobody. So first of all, how are you even going to build the credibility of coming back to these players and saying that, look, this thing I was saying actually does work. And this is what you stand to benefit. This is what your clients stand to benefit. This is how we all stand to benefit if we work on this together. But then I've seen people with just an idea. I've been in similar situations with you where we just pitched an idea and people were willing to pay us for just the idea. We haven't gotten there as a continent in Africa yet. Africans want you to struggle in the beginning, build it out, start seeing some success, make a name, make an impact. Then when you have enough traction, then you go to them, and then now they will jump on that success you've had. That's where we
Exactly.
are with funding in Africa. But if we had that flexibility where if the players are not on board, I just go back and I say, okay, that's fine. I'll deal with this one later. That would have given us the credibility to get everybody together. But unfortunately, we are not getting it.
Yeah, no, unfortunately, that's the situation on the ground. So, to our colleagues who are watching this live video, in case you have any questions, feel free to post them in the chat and we'll get Dr. Hamza to respond to those. So, I think, as a way of closing, I know right now there's a very important discussion going on in Dubai on COP28, where the public sector as well as the private sector are trying to think through what the way forward is going to be in terms of saving the planet. But what I believe from my end is that in order for us to actually save the planet, we need a very healthy population of people. So how do you see healthcare infrastructure and just healthcare systems, healthcare access in general contributing to this overall agenda of creating climate resilience?
So, you see, a lot of the things that we do that are degrading to this sustainability and to this whatever fights we are having with it has been brought to the fact that as a people and as systems, we are very reactive to situations. And part of that reactivity comes in the fact that we actually even wait to be sick before we go to a hospital. I would challenge any African country that has a very comprehensive preventative health plan in place. The best we do in preventative healthcare is education, right? But if we paid more attention to preventive healthcare, first of all, a lot of the diseases we are getting are coming from the environment, wherever we are living in. And if we want to sustain these, and we can teach people or implement ways in which we can improve sanitation, we can improve all these different things that we are getting from the environment. We are already halfway through, and it's going to do two things. It's going to improve the health of the population, and it's going to keep the environment safe. But we don't encourage anything preventative in healthcare, at least not from Africa. So our idea of preventive care is to tell people to come and talk to people about what they should do, but no system in place to actually push them to do what they need to do. So if I come and tell you, keep your environment clean, because maybe let's talk about malaria. If I say, if you have any stagnant waters, you need to clean them up. If you have any bushes around your house, you need to clear those. Make sure that you don't have any. Keep it clean, right? If I talk about that bit and I don't follow up to implement it, or there are not penalties for people who are held responsible, do you think I would, as a human being, I wake up every day, clean my gutters because I don't want stagnant waters, clear the bushes around my house and make sure I keep my environment clean just because I don't want cholera or I don't want malaria? No. What we are failing to do is that if we implement that, not only are we improving people's health, but we are keeping the environment also very good. Right? Any sustainability plan that you need to implement also comes down to the people. If you don't have a healthy people, their focus and their attention is not going to be on whatever you are talking about. What does climate change mean to me when I don't have health? My priority at that point is not keeping the environment or the climate. I don't care. I could care less.
Uh-huh.
But then if you have a healthy population, and now your problem actually is that you have the peace of mind to think about all these other issues. And everybody is going to come together because we definitely have nothing else to do. And you see that translate into so many other aspects of the conversation. There are countries that are so economically stable that the population are now pushing for so many other different things. That on the African continent is not even a conversation. We haven't even thought about it because somebody wakes up and they just want to make 3 square meals a day.
Yeah.
The same thing comes with all these efforts we are putting into keeping a sustainable environment, fighting climate change, all these things that we are putting together. We are doing it because people are not giving the attention it needs, because their attention is taken away into other things, and health is one of the big things. If I told you about the disease burdens at the beginning, if we are spending all our resources, our time as a people, either at the government and individual level, trying to fight diseases that could have been prevented, then this is not going to be our priority, right? But again, we have to be part of that conversation in order to make it sustainable. Is it possible? Yes. And I will always go back to the basics, prevention. If we can teach preventative measures, implement policies around those measures, they are going to benefit both spectrums of whatever we're trying to do. And people will be part of these bigger conversations.
I agree with you. No, thank you so much, Doc, for finding time to have this conversation with me. I really appreciate it. It's always nice to talk to you.
Who?
I'm saying it's always nice to talk to you. Thank you for finding
Always nice
time.
to talk to you.
Yeah.
It's been good coming on, and I think this has been long overdue.
Yeah, I know. We
So,
should have more of these.
it was great to have this conversation with you, and thank you so much for having me.
No, you're welcome. Thanks. Bye bye.
All right, bye bye.